Namaskaram. I am Dr. Shivasankar Dalai, Chief of Neurovascular Intervention at Medicover Hospital, Visakhapatnam. We have a very interesting case today, so that's why I thought that we should show it how to go about this case. In fact, I was in Berlin, and there's an operator who was showing that how complicated these aneurysms are, especially when there is a dissecting aneurysm in the P1 P2 junction. So many operators, they had problem in different conference. I've seen that they are showing the complication. Here we have a 78-year-old lady with very tortuous vessels in the level of the groin as well as the level of the aortic arch, as well as going up in the intracranial circulation. The vessels are very tortuous, and she had a subarachnoid hemorrhage because of rupture of intracranial aneurysm at the junction of the P1 and P2. So this is not a standard routine case, so I thought that will be very interesting for all of us to understand and see how we go about this case. Now we have done the angiogram and there is a 3D done. So Prasad, can you show us the 3D? You can see there is a dissecting segment of this P1 and P2 on the left side. You can see that the vessels are of a different contour. Over here there is a spasm, there is a dilatation, and there is an aneurysm with a nipple-like projection which is just projected outside the blade. We know that subarachnoid hemorrhage is a very dangerous disease. Once an intracranial aneurysm ruptures, there is a 30% possibility that the patient will not be able to reach a hospital. The rest of the 70% patient who reaches hospital with an aneurysmal subarachnoid hemorrhage, they run a risk of having a rebleed in coming 3 weeks. And a rebleed is very catastrophic. So that's why it is very important for us to treat these aneurysms. So there are 3 major issues in patients who have aneurysmal subarachnoid hemorrhage. Number 1 is a rebleed of the aneurysm. Second one is a vasospasm, and third one is a medical complication that can happen. So let's try and fix this aneurysm first. So we have the catheter going over there into the right vertebral artery, which was very tortuous, and we try to navigate these tortuosities and go and reach this aneurysm and put some coil loosely and then put a stent to heal the dissection in subsequent time. Can I go with the Navian and synchro? 5 French Navian we will go because I want to go a little distal. 6 will be little bit of resistance. We had some challenge getting into the vertebral artery ostium because the vessels are very tortuous. We have beautiful Parvati with us. It's a long time. And then we have Prasad, our cath lab technician and technologist, and we have Danish and Gauri, and then we have the smart Shinu behind the camera, and the team anesthesia led by Dr. Shweta. So the idea is to get a very stable out, put the synchro. So it's very important for us to understand in this situation we should have a very stable access. Table pitch. Roadmap out, we'll take a fresh one. Table pitch. Mag toku. Yeah, that's great. Give me a roadmap. Synchro. Then give me a hybrid. You can see there is an initial bend and then going down, and there's a lot of tortuosity. That's why I did not choose a 6F 5 hybrid 14. So that's the reason I did not choose a 6F intermediate or dyslexus catheter, because taking those bends will be really challenging. So let's go with a 5F Navian, which will be more trackable, taking all those difficult bends. I would love to have a synchro, but we don't have it, so we take a hybrid wire. So we just give a gentle J. So I need to give the microcatheter. With the microcatheter, we'll take directly. So that will be easy for us to navigate. So the dead space is less inside the Navian 5. So our idea is to just do coiling first. If we get a good stable coil mass, we just can put coil and get rid of the aneurysm, and then we put the stent. So sometime we do coil and stent, sometime we do stent and coil, sometime we do two microcatheters simultaneously, so that we have one microcatheter going into the aneurysm and then other one taking the stent. The stent is basically a scaffold, metallic scaffold, who will give enough support to the coil mass, and it will try to keep the coil mass inside the aneurysm, and it will not allow this coil mass to come into the parent vessel. Router 17? Okay. So why this triple axial system that we prefer? I have seen those complications in those meetings because there is a problem right from the access. It can happen, so that your the kind of access you have taken into the intracranial circulation is not stable. It just pulls back into the heart again and again. Then you will end up in a complication. And then second, you might dissect if you are very rough in going in this kind of tortuous anatomies. And then of course there can be other kind of complications. And the anti-aggregation is another issue that can happen. So we just prefer brilliant anticoagulant, that is ticagrelor, which is quite a good anti-aggregating agent with very less resistance compared to a clopidogrel. So the idea is not to push anything, but allow things to move very smoothly, and to create that smoothness we have to have multiple different devices going one inside another. You see the kind of, that's not so easy there. Roadmap out, table. So a 5-French avion to be gently navigated. So that's the region. We take a smaller one. So there is some spasm. Our pneumodyne is running. I will hope and wish. Come this side, Paroji. Can I have the screen closer to me? लाइट कम करो. Give me a torque. So here, give me one mag here, couple of mags. Table. Roadmap. You see this, you are having the challenge there. So you have to be absolutely good here with your vessel. You should see this beautifully, you can track, but that needs a lot of patience, and you just have to stick on there. instead of being harsh or pushing something which is not going, you have to find out the reason why it is so, rather than trying to be really impatient or rough. So one inside another, that will probably help. God is kind, so we are able to navigate things little far. Okay, roadmap out, table. So you straighten the system, you reduce traction, right. So we leave it here, table, and then we go into further deep inside the brain circulation, roadmap here. So can I get a roadmap here? So now we see that everything is under control. Yeah. Go back once. Forward. Forward. Okay, back. Okay, roadmap on that. So now we just navigate everything slowly. You see the kind of loops that you have to take is incredible, and so that gives us a lot of confidence in terms of, so keep our eye on the distal end of the wire, stay away from going close to the aneurysm. Basically with the wire you need a good control. So that's the reason the 6F will not take it here, all these loops. So hopefully we made a good choice. Roadmap out. So keep an eye that this bend should not get accentuated. Patient is light. Table pitch. So we have this table. We have ballast here, which is doing its job. Roadmap on that. Look. No, keep showing me. Yeah, perfect. So I'll try and see whether I can gently navigate inside this aneurysm. That's going to be the real ask here for me. Torque. We might have to reshape the wire a bit here. Sometimes you need to give little space. Okay, so we will shape it a little bit. Paruji?
Sir.
I would love to have a synchro, but we don't have it right away. Take it. So what are the causes of brain aneurysm? Why somebody will have aneurysm in the brain? So there's a question, say all the patients and their relatives they will have. We do not know significantly what is the cause, but we know that there are many things that are associated with aneurysm, like female gender, like stress, like smoking, cocaine abuse, family history, genetic disorders like Ehlers, Danlos and others. So they are the causes for somebody to have brain aneurysm, but there could be some other factors too. Torque. So sometimes the projection doesn't help you, then you have to take another projection. So we will work out on them. So you can see that it's just flipping in and out of this. So sometimes we basically shape a catheter also. Okay, so we can go to another angle to understand what is happening here. All flush are running.
Running.
So we are inside the aneurysm. So we try. So my microcatheter is there. Save it. So you can see the tip of the microcatheter is sitting inside this aneurysm. Patient okay? We'll go with the coil 3/8. 3/8. Even the 3/6 is okay. This is, yeah, 3/6 is fine. Yeah. So we'll go with the 3/6. We have just cannulated the aneurysm. You see that it can pose challenge at various places, right from the groin, and with this tortuous iliacs, and then you go into the arch. It has an unfolded arch. Then you have the vertebral artery origin, which can be hostile, and then the vertebral artery can have 360 turns. That makes you very difficult for you to push your devices up, and then you can have an aneurysm which will have challenge cannulating. You just have to go through everything. 3/6 though coil. 3/6 super soft, yeah. So I'm trying to release the stress or the tension or the from the catheter. Good. Mm-hmm. Come this side. Come this side. Bye, auntie. Vankai, eh? Kaun khailo aji ma? So Parvati just finished her lunch with vankai and potato. So easy, yeah? So I'm feeling a little bit of resistance here because of all the tortuosities. Because the coil has to take a lot of turn before it reaches the aneurysm, so I'm feeling a lot of resistance here. The good thing, we have taken very distal axis so that the stress is less. Thank God, it's just coiling so beautifully there. So it's trying to come out. So in that situation, what we will do is we can put the stent and then one more try we will do. Then we'll retrieve the coil. So one more try to go inside the aneurysm and put the coil. If not, we can put the stent. So we retrieve the coil. Here we can recannulate this aneurysm. Pull it. Stop. Give me the wire. all the way to the vertebrovascular junction. So we are there. Chal. Can we go ahead with the coil? Out. So I won't be interested to put more coil, just one coil to protect the dome, because the stent is going to heal the dissection and take care of it, but at least one coil will give me a lot of confidence. Good. .36 is a good size there. Come here. So everything is under control. Now it's going much smoother because we have just had the navion sitting all the way into the vertebrovascular junction. So these are small things that's going to help. So now this coil is sitting the way we would love. Thank God. So this is absolutely perfect. You can see the ball of coil sitting right in the aneurysm and taking over the aneurysm, trying to exclude this aneurysm from the circulation. This looks absolutely rock solid, quite happy. And in case you don't have a stent, then you have to put more of the coils because you need a better occlusion, or if you can have a balloon, you can have better occlusion. But here, because we are going to go with a stent which is just going to divert the flow away from the aneurysm and promotes endothelial healing, then you are going to have a great occlusion long term. So you're not worried about really pushing in a lot of metal into the sac of the aneurysm here. So can we detach this coil, Paro? So Paroji was interested to go to Mudasar. So unfortunately not today. कह रहे इसमें बैटरी है कि नहीं? No, give me one more. So the best thing is that we could manage to have the catheter just coming out the neck of the aneurysm. That means, the moment you just detach this, the coil, the tip of the microcatheter will be outside, and it's very nice for us to take it in, take along, go into basically for the stent. Can we go to the other angle and see what is happening there? Keep moving. Perfect. The new one? Go back to working projection. Max mag. Table. Perfect. Can I go with another coil? 2 में क्या दे सकते हो आप? What do you have in 2?
2.6, 2.8, 2.10.
2.6. So very beautiful, very beautiful. I just love this. You see this, the first coil, just taken care of it, and we have the parent vessel flowing well, and we just go with the 2.6, one more coil, and try to fill off a little bit of the fundus, and once we get that occlusion, then we will think of the stent.
2.6, shall I open?
2.6, yes.
Super soft coil, opening.
So you see the framing has been beautiful, and patient is doing absolutely fine. Parameters are all good. Good. Yeah. Four years back, exactly same aneurysm we have treated. Exactly same age, same anatomy, and same plan. So again we have the situation here where the catheter has jumped out of it, so I am not going to put this coil here, rather I'll put the stent. Go ahead, let's retrieve the coil. Pull it, Rita. Pull it. All right. So now we will go to a different projection altogether. So we will go here. So we will go to the distal PCA at LAO 69 and caudal 38. LAO 69 caudal 38. Table. Okay, we'll just check how it looks like. This looks perfectly okay. Okay. Fine. So give me the wire. Roadmap on that. So this anatomy makes it tricky because you don't have a clear view of what actually need to be done right away, but looking at different projection, making a map in your mind will give you much clarity. So good that the microcatheter has been pulled out from this aneurysm, which we are not interested in anymore. We want to cross it, the torque. We want to cross it, go distal, and we deploy a stent that way. So we will go to another projection. Can we go there to RO 38? RO 38 will give us a good view of the distal branch and table, roadmap out. So you see, we just have to be ready with multiple plans and navigate one from the other. Roadmap here. Good, good, good. So here we are trying to make a little curve or a J and then push the whole thing to the distal. That's how you get inside the distal branch. But I would love to go in another one. So here what I'll do is I will go through this. This would be better for me. This is one ideal for me. J is helping me out, and this has taken the curve that I wanted. It's a very tough one, but thankfully it's being cleared now. So we can see that we have taken a distal bend very beautifully. Roadmap out. Table please. Yeah. See this. This is exactly where we want it. Native. See this? It has come like that, it's gone like that. Here. Epicranial. Dot, this is the 3 centimeter dot, the distal and the proximal, and the catheter continues here. So once we put a stent over from there to here, then you got it cured. So that is what is our goal. And now because it is a dilated segment, don't take a 2.5, rather take a 3, because we don't want that way. We always want that the stent should be opposing the wall, so that the chances of thrombus are less. Roadmap on that. Roadmap not required, so we know what is what. So you're very, very clear about it. So these are the fusiform segments need to be taken. So I can start my stent from there. Okay, roadmap here. Can we go with the stent? Baby Leo is what we are choosing at 325. So very nicely projected. Working angle. Can I have the lights on? And we have everything going according to plan, thank God. Baby Leo 3 into 25. Let's go ahead. Yeah.
Opening 325.
क्या भाई ओ इसका देना हाँ नो नो ये भी दे सकते ना हाँ ओके वो दे दो But that's not right. Paro, you're cheating, yeah? Okay, so let's go about this. Go ahead. So we are going ahead with a baby Leo 3 into 25 in a router 17. The best part of it is you can do the coiling and the stenting, so you don't have to change the microcatheter. And the best part of this is you know the proximal and the distal end of this marking the 3 centimeter, so your stent is going to be a little short of those two markers. Come here. Now you can realize that how things have gone. So far so good. So let us start deploying from here. This is a better position, opening up very well, because you might lose some length. You can see the stent is opening very well. You take your time, just push it out. Don't try to unsheath. That will not work. And if you want, try to self-fit a little bit. Now roadmap out. I know where is my distal position. I don't need a roadmap anymore. And I know the proximal position of the stent. So it's just about an inch, 2.5 centimeter stent at 2.5 millimeter. So here you want to push the stent a little bit, and then you push it further and push it out. Perfect. You can see there's a very, very well open stent here, and you can see your catheter going through the stent very well. That is a maneuver to tell that the stent is well opposed, the stent is well opened. You see this catheter has been taken through the stent, distal end of the catheter. So that means the stent has opened up well. And then, of course, see this? Extremely beautiful. See, the aneurysm has been coiled, a stent is placed which will take care of this fusiform segment dissected, and come this way. Go that way. So you see the coil mass, you see the stent. Stop. Now you can see the length of the stent through and through. You see this? You can see the stent, how well it has opened up. Can you show me the last run? You see this? Stop here. You see the stent from the distal end all the way to the proximal end, opened up very well in front of the aneurysm. Coils are there in the aneurysm, and the flow is beautiful. That's how you should plan to treat your aneurysms. Extremely good. Thank God, it looks so beautiful. We will stop here. One lateral le lo, then we will take a check angio after 15-20 minutes. You see the lateral view, it looks elegant. You see the stent, you see the coil mass, and you see the angiogram. Looks good. Epicran, and the aneurysm is completely excluded from the circulation. There is no more filling of this aneurysm as planned. First of all, you straighten the vessel, that reduces the flow stress, and then you have a stent which is just going across the neck of the aneurysm, which is absolutely fantastic. We will do a check angiogram after 15 minutes before we stop the procedure here. Thank you all for watching this interesting complex situation. Thank you all from everybody here in Visakhapatnam Medicover Hospital. We are signing off and see you next time. Thank you so much.